guys, break's over. So my name's Priscilla, I'm one of the third years. I'm going to be presenting on debriefing. This is under the umbrella of wellness curriculum. So we, as part of the wellness curriculum, got ALI, ENU, I think that's how you say it. They recommended that debriefing is something that we should talk about as part of the wellness curriculum, and this is the reason why one of the topics for wellness is this. So special thanks to all these doctors who helped me, Dr. Stetz, Wolfram, Kwok, Ahmed, Dilip, and Berland. So before we go forward, the objectives of this lecture is a brief overview of debriefing itself, as well as acknowledging the variety of debriefing methods. And today we are going to teach you, or I'm going to teach you, the elements of the PEARLS method. So, what is the purpose of debriefing? The purpose is to facilitate discussion of actions and processes that happen during the actual resuscitation or whatever event that occurred. It's also to encourage reflection, as well as assimilate improved behaviors into practice. So, what events do you guys think cause us to decide to do debriefing?
Poor outcomes.
Codes.
Poor outcomes.
Poor outcomes. Mistakes. Okay, maybe not. Things that you perceive as mistakes that you can improve on. So these critical incidents include usually some patient's deaths. This can be on the floor, in our ED, it could be anywhere in the hospital. Usually also includes resuscitations. They can be trauma codes, cardiac arrest. Could be also like sepsis codes, for example, or respiratory distress notifications, especially in pediatric cases. I feel like every time there's a pediatric case, there's usually a debriefing of some sort. There's also other things like you mentioned, poor outcomes. It could be an adverse drug reaction. If you guys remember the last M&M that we had, a adverse drug reaction to a medical mistake. Angry family members, you have a really bad interaction. It involves a lot than an entire ED. Also, in pediatric critical events, there was a study done of EM program directors as well as PEM fellowship directors that said that they would also include other events such as sudden infant death syndrome, significant injury, child abuse, as well as any clinical errors that occur during the case for a pediatric case to instigate a debriefing of some sort. These are other indications for debriefing that can make you cue you to have a debriefing occur: near miss events, patient harms, arguments between clinical providers, consultants, and ED providers, for example, or even in between medicine and other consultants. So what are the benefits of debriefing? So not only is the debriefing to help us, assimilate new processes and improve what we can do better. They also help us. It's a time frame where we can, talk about, the personal impact of the grief that occurred during that event. It could be also talking with your colleagues about, I felt the same way you felt when this happened, or, I felt really bad that this patient passed away, so forth and so on. Also normalizing that you're stressed out when an event's going on. You're sad, you're scared, all those reactions that, we don't have the opportunity to talk about most of the time, and we all talk about it after work. We go to the bar, we talk about this, or we talk about it with our significant others to help us feel better about what occurred. And then also talking about healthy coping mechanisms, like what do you guys do after a really bad event? How do you decompress? And that's something we can share during a debriefing. It doesn't always have to be, hey, you can do better on your airway by having X, Y, and Z backups. And a meta-analysis was done of team-based debriefings that after clinical events, having a debriefing for teams who had debriefings versus teams that did not debrief, they improved in, after clinical, showing that with CPR, return of Ross, neurological outcomes, hand-off compression times, and time delayed to first compression. The American Health Association, the resuscitation guidelines actually recommend that debriefing should be a part of any resuscitation. So, what are barriers to debriefing in the ED? What barriers do you guys think of?
Time, space.
Time, space, busy, time. Anything else?
Desire to leave immediately after shift.
Exactly. All right, that's true. All right. So, time. When do you guys debrief? Like, we're in the ED, we're very busy. We're all thinking about, while you're in that resuscitation, oh my gosh, I have 5 other patients I'm thinking about. The ED is blowing up, so forth. So that's one barrier. Another one is scheduling. So it's not just the physicians who are part of the debriefing, it's the nursing staff, the technicians, and your consultants who came in, trauma code, STEMI code. They hopefully would be a part of the debriefing too, so that you can improve the process. Also, location. Unfortunately, we don't have a designated debriefing room. If you're in CCT, we usually debrief either in the trauma bay once the room is cleared, or in and around the computers in that area. Or UHB is a location nightmare, unfortunately. Where would you debrief? And lastly, some individuals, certain surveys have been done where they say one barrier is the knowledge of how to perform a debriefing. At the attending base, the senior resident base, or the junior resident base, what does the debriefing actually entail? So today, we're going to help you with that last barrier, okay? How do you conduct a debriefing? Senior residents, I'm a newly turned third year. I don't know exactly how to perform a debriefing. So this was a great review for myself. And for you, hopefully. All right, so there are a lot of different ways to debrief. There's all the lists. We're not going, and there's the SHARP method. There's also I don't remember what this acronym stands for, but OSAD, O-S-A-D. We're not going to go over those, okay? This is a lot. One method, if you guys remember Juliana's lecture last year, if you were able to be at that lecture, is called the second victim syndrome, and she went over one debriefing style. This is a slide from her lecture. It's called the Mitchell Model of Critical Incident Stress Debriefing. It's actually one of the most popular debriefing methods. Its objective is to alleviate the effects of the stress from that event, allow providers to go back to their routine functions, and help restore the health of their staff. So these are the steps for that model in particular. So ground rules is establishing, the safety of the environment that you're having this discussion with, that this is a safe environment, and the purpose of it, that you're saying that, hey, we are debriefing. 2 is what actually happened, talking about the actual facts of the case. Similar to SIM, after you've done SIM, you guys say, hey, what are the facts of the case? This is very similar. What actually happened? So everyone's on the same page, the timeline of events. 3, what were people thinking? So just asking questions of your group. Hey, how do you guys feel? It can be anything. It could be any emotion that you have. It could be that you felt really bad about how a central line was placed, so forth. And then allowing people to express those reactions, not going straight to correctional statements, but allowing people to express how they felt. And lastly, and 5, you can discuss symptoms that can happen from having those reactions, and that's an opportunity for screening for second victim syndrome. And then 6 is teaching and learning improvement. So that's the 6th part where you can talk about teaching points during that time frame. Normalizing those symptoms that you're having, and then lastly, having questions or final statements. So this is one method, okay? Now, PEARLS. PEARLS it's a very long acronym. It's a short acronym for a very long statement. It's the Promoting Excellence in Reflective Learning and Simulation Approach. A mouthful. Short, PEARLS. So the first step is setting the stage. It's very similar to the Mitchell model. You're going to say, hey, we're going to spend X amount of time on debriefing. And this is a safe environment. We are, what we talk about, we're not going to talk about outside, so forth and so on. Second is the reaction. So exploring people's feelings, how they felt during the event itself, or resuscitation. Some initial questions that you can ask is, hey, how are you feeling? Any initial feelings that you're having? Third is the description. So we're going to clarify the facts, and then this is where you ask, as a senior resident or as an attending, you ask your juniors or your colleagues, hey, could you give me a summary of what you thought happened, or what was the working diagnosis? Does everyone agree? Did other people think something else was going on? 4 is analysis, and we're going to touch base on analysis because that's the most important part, and we're going to talk about that in the next couple slides. And last is application summary. So we're talking about the takeaways. The takeaways for the individuals we're talking about, the 2, or whoever's leading the debriefing can have some summary topics that they want to give to the group. Like I said, we're going to talk about the analysis next. Alright, so the analysis, the purpose or the objective is to analyze different performance domains. These can include decision making, technical skills like the central line, communication. Everyone remembers when you're doing ACLS, the videos like closed loop communication. Did that actually even happen? That's something we could work on. Resource utilization, sometimes you're in CCT or even the resuscitation bay in UHB, we don't always have as many individuals we have, so maybe that's something to think about next time. Leadership, situational awareness, teamwork, and then there are different methods for the analysis section. There's 3 approaches. 1 is the learner self-assessment, 2 is the focus facilitation, and 3 is provide information. So for the first 2, we're going to talk about in the next 2 slides, learner self-assessment and focus facilitation. 3, providing information is like if as the leader you say like, hey, I noticed that you were very nervous. I noticed that you had only the DL available and the flightoscope with you. Maybe next time you want to have a bougie with you. So something that you as the debriefing leader can say that you noticed to improve for information for your that individual. So for learner self-assessment, you can use plus delta, what worked well, what didn't work well, and then what you could change for the future. This is an easy thing to use. It's non-threatening. It's useful for focusing on specific behaviors, but it's not a substitute for reflective debriefing. Really, you're not really reflecting. You're thinking on these actions that you performed and what you could have done better. It can actually be used as a standalone debrief for yourself. So say you left the resuscitation and there was no opportunity because of all those barriers to do a debriefing with the whole group. You can try to do this for yourself. Second is focus facilitation. So this is a debriefing process called advocacy inquiry, and these are opening statements, starter statements that you can use to help elicit information to advocate. So you as the group leader, you can say, hey, I noticed this for you, so that one, it doesn't feel like you're judging that person, because some people are like, hey, you did this. No, it's, hey, I noticed that you did this, so that you can expand your thought processes and that everyone can hear what you were thinking and what you observed. Or you can also do the inquiry to facilitate, hey, what were you guys doing? What were you thinking when you were doing that? So that it's an open conversation. And this is more reflective for debriefing. Now, you guys notice all those nice little pictures? There's a great card that that was developed. Oh, I think I missed the slide. Oh, that was made by the Pearls. It's a great slide. Sorry, guys. I don't remember where I got the sources, but this is a great slide that you can have on your phone so that you guys can use this for debriefing after resuscitations at work. So to regroup, what is Pearls? You're going to set the scene. You're going to explore the reactions. You're going to clarify your facts, and then you're going to analyze. So you're going to use either plus delta, advocacy, inquiry, or give some advice. And then before you conclude the entire debriefing, you're going to ask, does anyone have any questions, any concerns that they want to bring up? And lastly, you're going to summarize by doing takeaways for each individual who's in the debriefing, or the attending, usually the attending who's leading the debriefing, or the senior resident can drop some knowledge bombs. Okay. And this is something you can download. It's easily Googleable, and I'm actually going to ask you guys to Google this or use the link that's on the screen so that you can download it onto your guys' cell phones. Alright, So that's the end of my part, which is the lecture part. We're going to actually do a small group. So that's going to entail a video, all right? And then we're going to do 2 debriefs. So we're going to give you, I'm not even going to say what it is. It's going to be 2 debriefs on the video. And then after that, we're going to break up into small groups. We're going to have small group leaders, and we're going to help learn how to do the PEARLS method so we can reinforce that knowledge. Okay, let me see if I can get this up though. Oh, yeah. Is it volume?
It's muted on the podium.
How does one pause this? Oh, yeah. Oh, there we go.
Yep.
Okay. Oh, wait, baby!
Get a crash cart.
Oh, wait, baby!
I'm not getting a pulse.
Code blue and 80 alpha.
Out of here. Start compressions. You're running the code.
I've never run a code. Do you want an amplified carb?
He's in charge.
Page anesthesia. Rhythm. What's rhythm? PEA.
Sure shocking.
Make those compressions harder and faster. Prepare to innovate.
It's been 24 minutes. It's time to call the code.
No! This is my code. You gave me this code. She's 21 years old. Parker, man, you need to feel the ribs crack.
That's enough.
No. Move. I'm not giving up.
I said that's enough.
Because you can totally interpret what the rest of the statement. I like how the word silent. Yeah, Polly all dark over there. Her pupils are fixed to silent.
Your end tidal CO2 is less than 15 for the entire code.
That doesn't necessarily mean that
Yes, it does.
she's been without oxygen to her brain for 26 minutes. Congratulations, you got her heart beating again, but she's brain dead.
Sorry guys, before we, one second, I accidentally closed the thing. So if I could have Monisha and Dr. Stutz in the front while I pull up. Okay. Alright, if you guys can do me a favor, you guys are going to open your computer, not your computers, you guys have iPhones. Your iPhones, and what you're going to do is go to this. Oh, is this not showing up?
Smartphones.
Smartphones. Androids. You can go to this website, or you can go to just Google PEARLS debrief tool, and I think it's the first link. And I want you guys to download this. I'll give you like a minute. You don't have to download it; it should populate. And then I want you guys to watch Dr. Stutz and Dr. Dillon.
I'm the intern.
Oh, all right. Did everyone get the slide or the little tool card?
Yeah.
Found it? Okay. All right. So this is one version of the debrief. All right. I want you guys to observe. Think in with the PEARLS method. Watch this debrief. What could go better? What could go worse?
Can we talk about what just happened here today?
Yeah, let's talk about it.
So I just, what were you thinking? I mean, the thing is that you pulled out a book. How could you pull out a book in the middle of a resuscitation? I at all. And then after that, I mean, you took over for this other guy doing compressions. What were you, and nobody was bagging anything through the entire thing? Like, were you just hoping oxygen would somehow magically get to her brain? No, I'm sorry. What? Explain to me what was going on. And no, are you gonna say anything? I can't even believe it. What did we even go through? I mean, is residency for nothing? I don't know. I don't even know what to say. And then after all of that, I don't even know what's gonna happen. Well, good job. Good job is all I have to say. Whatever.
I feel terrible.
I have nothing more to say about that.
End scene. Okay. Alright, so that's one version of a debrief. That could actually happen and probably does happen at some facilities, some residencies. Alright, so for all you second years who are going on SICU, breathe in, let out. You can always come home and vent to us. And if something is really going really badly, second years, you guys can tell us. You tell your chiefs and tell your PDs, okay? Because first year we had badness happen, and our PDs were bomb.com and helped us take care of some things. So think about that, all right? So it's okay, if you're on a service and they yell at you like that, that is not appropriate, okay? Monisha. Sorry. All right, so we're gonna do our second debrief, okay? With Dr. Stetz and Dr. Ahmed. Oh, so round of applause for Monisha. Channeling that resident, guys.
Oh boy, that was so hard.
We're just going to spend a few minutes debriefing and discussing the case. First, we're going to talk about how you're feeling. This is a safe space, and anything you share here is amongst us. This is for you to share your feelings. Then we're going to talk about a little bit of what went well, some of the stuff that you could have managed better. And then we're going to go through some of the take-home points and how you can apply it to your clinical practice. So we'll start with how you're feeling.
I mean, I feel terrible. I can't believe I pulled out that book, and I mean, I was so nervous. I didn't know what to do.
I hear what you're saying. So let's go through a little bit of how you think, what in your words happened during the case.
I just felt so overwhelmed. I couldn't think initially, and then I just realized I didn't want her to die, and that we had to go forward. And then I just ran the code. I don't know. I didn't want to stop. I didn't want her to die.
What do you think could have gone better during the initial parts of the case, and then as it progressed from when they moved into the resuscitation room? What do you think could have gone better?
I mean, it was my first code, so I just should have been more ready. I just wasn't ready. I felt overwhelmed.
So now that we're clear what happened during the case, we're going to transition a little bit into some of the bits and pieces of basically what you think you could have used in addition to what you said before, what you want to do differently.
Well, I'm going to go home and I'm going to study that algorithm, and I'm really going to think about this. I'm going to watch some YouTube videos, and I'm just going to think about it a little bit, because I know I could have done better.
So what specifically would you want to change going forward if you had to do this again?
I mean, I think I need to be more confident. It's really hard as a junior resident to be in charge, and I need to be more confident. If I felt more confident, then hopefully I would have gone right in, and maybe she would have come back sooner. I don't know. I mean, at least she didn't die. I don't know what's going to happen, but she didn't die.
And so just as a summary, after hearing about the details of the case, what's one take-home point you think you could use going forward in the future?
I'm going to try to assign jobs better, and then make sure things get done, and get help from my team, because I think my team could really help me.
Great. Thank you so much.
Thanks. I feel a little better.
So this was a model debrief. It's running through the PEARLS method. Obviously there's gonna be moments where, Dr. Stetz was saying like, hey, I was really scared, like saying those things, and we, as a senior residents, for our junior residents, or I'm sure our attendings also hear from us that, we get those emotions, and having someone else to hear that and having that other person support you is helpful too. And that's not, the debriefing doesn't always have to be about actionable things. It can be talking about just your emotions that went on during that case or that resuscitation. So we're gonna break up into small groups. We have about maybe